I've been in practice about 12 years now or so. I'm in an orthopedic group in South Florida in Boca Raton and Delray. I've been working with ITS, utilizing all their different products and this Hallux Osteotomy system for 7-8 years now. I went to Bear University, did my residency down in Plantation, Florida, Westside Regional, and I've been with the same group since I got out. So without further ado, we're going to jump into this. This is the Hallux Osteotomy implant from ITS. This is a titanium implant. It's an intramedullary implant that is basically designed for mild to moderate bunion deformities. So a little bit about bunions, the background. The bunion was first described in 1881 by Riverdin. And you guys probably know most of this background, but just for completeness, bunions affect 9% of the population, 31 to 60, and 16 of those over 60 years old in the United States. Females, 2 to 4 times more frequent than males. Your normal bunion angle is an IM of 9 degrees or less. That's the intermetatarsal angle between the first and the second. And the hallux abductus angle is usually 15 degrees or less. And again, we're talking about mild to moderate bunion deformities. The more severe bunion deformities are usually not treated as successfully with this. You usually need more of a base wedge or a lapidus type fusion to address that severe type deformity. This is a little descriptive picture of your mild all the way up to moderate and severe bunion deformities. Our traditional bunion correction, the way I was trained, was really a chevron type, Austin type osteotomy with 1 or 2 screw fixation. This is the way I started my practice, was performing them this way until I came across this ITS implant and thought it was intriguing, decided to give it a shot. I'm not sure about most of you guys, but I was a little skeptical when I first looked at this implant. Wasn't really sure how well it would work, wasn't sure how stable it would be. It seems like kind of a scary type procedure, making a transverse cut, shifting this thing over and wondering how it's really going to work. Here's some pictures of our traditional bunion fixation with 1 or 2 screws, your standard chevron type cut in the distal metatarsal. So these are some photos that I took from the internet, which, showing these probably moderate type bunion, maybe you consider it severe, with these large incisions. And certainly there's a place for this. But that's one of the things that we may be able to address better, is correcting a large bunion with a much smaller incision, since for a lot of people it is somewhat of a cosmetic type procedure. This is your standard incision with your standard bone cut. One of the things that we usually do with a bunion surgery is you're removing this entire medial capsule and medial structure. You're entering the joint, which seems like it causes a lot of swelling, a lot of stiffness in order to get the bunion corrected. So with this implant, there may be a different way to do it, that we might not have to destroy as much of the healthy tissue. Here's another incision, which looks like a fairly small incision, but it's pretty visible right on the top there, which I would think some people would want to shy away from that. Here's a couple of medial incisions, which probably would give a pretty good cosmetic result, but you could argue that they're maybe a little distal, and you're probably going into the joint, where if we were able to avoid that, we might be able to maintain some more normal range of motion and a little bit less swelling. This is another bunion example from the internet, which I would argue looks pretty good. But again, you've got a pretty large incision on the medial side, and you may have had to take off more than with some other type of procedures. This, my question is there a better way to fix a bunion, which might be less invasive, getting the same amount of correction, maybe a little bit more, depending on how you perform it. This is one of the bunions that I corrected utilizing the ITS. There's a little incision on the side here, you can see that. And then I did a Taylor's bunion correction on the outside here for this patient. So in what way is the ITS implant different or better? The incision could be a much smaller incision, depending on how you end up performing it. Initially, when I started with this, I was probably making almost the same size incision, not realizing that it could be done a different way. I've gone definitely through a kind of a learning curve from where I started with this implant to what I'm doing now. And I'm going to try to show you a little bit of what I'm doing now compared to how it was in the beginning and what might be a little bit better. I would argue you get a pretty large correction with this. Compared to some bunion procedures, you may get a larger correction than your traditional chevron or Austin. The implant, since it's an intramedullary implant, is very stable. I'm not sure how stable two-screw fixation is. I've seen them shift a little bit or rotate. We're doing weight bearing immediately with this type of procedure. We're able to perform some of these bunions without entering the joint capsule itself. So we're able to maintain better range of motion at the first MPJ. And I think you have less swelling because you're stripping less of the periosteum. You're not opening up the joint as much. We're also able to get a tri-planar correction, which has recently come into pretty much popularity. Everybody's talking about that now. Whereas the chevron, you are not able to correct the pronation of the great toe quite as much. This is an interesting thing about tri-planar correction that I came across on this Foot Innovate site. I don't know if you guys ever watched the videos on this, but this is showing how when the great toe is anatomically aligned, like here on the right side, you see a normal 90-degree, roughly 90-degree angle on the lateral side of the metatarsal head, whereas when the toe or the metatarsal is pronated, you effectively see this rounding off of the lateral aspect of the head when the head is not necessarily changing shape. If it progresses far enough, maybe it changes shape, but a lot of times it's just the way that this is visualized on the x-ray. This is a cadaveric specimen where in the anatomic alignment, you can see the head looks like a normal shape on the left. And then when the head is pronated, you see a more rounded presentation to the head, which I thought is kind of interesting. This is a picture of the first metatarsal head, how the frontal plane is abnormal with the weight-bearing CT, which I don't have one of those, but I thought this is pretty nice to actually show a depiction of what this looks like. And it's the average angle is about 22 degrees, which we need to correct in the frontal plane. So this is kind of what we're doing with the ITS implant, is making a transverse cut and shifting the head of the bone over. You, according to the technique guide, you're supposed to be able to use any different type osteotomy that you'd like, but I've tried initially using just a chevron osteotomy since I wasn't sure if it was going to work well, and really found that this transverse osteotomy is the ideal cut. You really don't need to take much of the periosteum off in order to make this cut. And you can also take a small wedge if you need to derotate the head. So how exactly does this thing work? This portion on the left here is tamped into the intramedullary space after you make your bone cut. These barbs bite the first metatarsal from the inside out, and then this screw is a locking screw, and it locks into this distal hole here. And it's not a true locking screw. You can drive it all the way through if you're not careful, but when you put that in, it allows the barbs to open up and bite a little bit more from the inside out. Here's another picture of what this looks like radiographically. This is one of the first ones that, or one of the earlier ones that I did, where I was removing the medial eminence, making this bone cut just proximal to where the sesamoids are, and then putting the implant in. And now I'm transitioning to trying not to go into the joint capsule as much and make the bone cut a little bit more proximally, so that you don't destroy as much of the joint. So just going over the technique of this implant, there's 3 different sizes. There's an 8, a 9, and a 10 millimeter. They're small, medium, and large. And I would say usually the medium size is the one that we use most of the time. Again, there's an intramedullary locking screw, and this is for mild to moderate bunions with a hallux valgus of up to 25 degrees. That's a hallux abductus angle. The plate implant itself is approximately 1.5 millimeters thick. If this ever does need to be removed, a very small incision over here can be made, taking out 1 screw, and then backing this out is pretty simple. Just showing you here, there's a normal 2 millimeter drill. You have your handle, your standard AO handle here, which attaches both to the screwdriver as well as the insertion device, so you switch back and forth from this. There's a measuring guide that either measures through the implant itself while it's attached to this handle, or it can be used free-handed, and you can measure from either side depending on how you're using it. So this is your measuring device here. Once you've made your bone cut and shifted it over, you have your 8, 9, or 10 millimeter, this throwing star type device. And then this is the implant insertion device, where the implant sits in here and you screw this little thumb screw into the implant. And then the handle goes on here, and you can tamp this with a mallet to push it into the medullary canal. So some of the contraindications for this implant, like anything else, is existing infection. Osteopenic bone, you might want to be extra cautious with this. I've found that in some of the patients, if you're having to do a revision type bunionectomy, it may not work as well. If somebody's already had some sort of a chevron type osteotomy or distal bone cut, there's not going to be a nice intramedullary space for this implant to go into. So you do need to be careful with it in that indication. If somebody's had only, say, a silver type procedure, and it needs a second correction, it still works quite nicely. You just need to make sure that that medullary canal is preserved. So this is inserting the, or putting the insertion device into the handle here. This has a nice small tray with just a few instruments. So here they're talking about you can use any type of bone cut, chevron, Austin, Homan. I would really recommend mainly a transverse type cut. And this is the way I started doing it, where you remove this medial prominence through kind of a standard medial type incision. And I was doing an open adductor release, and now I've transitioned to doing a percutaneous adductor release. And I don't find that you actually need to remove this medial prominence all the time. A lot of times you can go a little more proximal to that. Here's a clinical picture of one of the initial surgical cases where I exposed the entire joint, and I'm probably making this bone cut another 7 to 10 millimeters proximal to where it's shown in this picture. I just find you need a little more real estate for that screw. You need to make sure there's almost a centimeter between the screw and the bone cut. Otherwise, this could shift a tiny bit. That's one of the tips that I'd make sure about. So again, here's your sizer, checking what implant you need. A lot of the time, I'll try to just free up a small amount of the periosteum dorsally and planarly enough just to make this cut. And then in order to shift the head over, I'll put a freer in here and push it over with that. And then also put the freer in just a little bit on the other side of this proximal metatarsal and just free up a little bit of the periosteum, just enough to get this to shift over to where you want it to be. You can probably shift it anywhere from 50% to 75%, and the implant will still seat nicely and you'll still see it heal very well. This is a picture of the implant itself being put into the bone here, and then there's a guide wire that can be placed through here if that's needed for stabilization or to take an X-ray. They're showing here that you can rotate in several different planes before you place your final screw here. So if you need the frontal plane correction, you can do that here. Once you've removed this medial prominence, you're kind of set with your frontal plane correction. So if you're going more proximal, you have the rounded aspect of the metatarsal here, so you're not on this flat surface. So I would argue to do this a little more proximal even, so you haven't bought that frontal plane with that medial resection. So here's a picture tamping the implant in. I'll put a mallet on the end and tamp this in just to where it's the right spot. You want to make sure right in the center of your implant where this hole is, that's at the correct spot, approximately 7 to 10 millimeters from where you made your bone cut. Again, this is your standard 2 millimeter drill. Usually this is an 18 to 22 millimeter screw roughly. I've found every once in a while, if you have difficulty and this screw bites, but the implant is still a little bit loose, if you say pull on the toe and the implant is not seated 100%, you can drive a second screw from this area of the implant into the proximal metatarsal, kind of at an oblique angle, almost like a kickstand type screw. So that gives you a second point of rotational stability if you need it. I've had to do that a couple times. And you can use the same screw that comes with this implant for this regular indication. Again, here's your measure where you can measure off of the device through the insertion device, or you can put it directly against the bone depending on what you feel comfortable with. I haven't done this, but if you remove this thumb screw, you can put the actual screw that you measured for through this implant before you remove the insertion device. As you see it here, putting it through here, I've usually just done it this way, put the screw in like that so I can see it better. So the screw needs to sit flush with this implant, and one area of caution, if you drive this too far, it can go all the way through the implant into the metatarsal head. And really, you would need to remove the screw. You might need to drill a new hole for that. So just be cautious when you're putting this in that you haven't drilled it too far. This is a picture of the tray, which is pretty simple. Has a few K-wires here for stabilization. This is your handle, your drill, your screwdriver bit, your measure, your screw sizes up to 24 millimeters, your different implant sizes, then the thumb screw for the insertion. So going on to a few of the case presentations, this first one is probably the way that I would try to do this now. If I had the choice after doing all the different cases, this would be the ideal. So this is a 22-year-old female, minimal past medical history, IM of approximately 15 and a hallux abductus of 48. The abductus part, we're kind of pushing this a little, pushing the limits of the correction with this. She does have a slightly elongated first metatarsal if you're looking at where it lines up here. So that was something that I wanted to correct during this case. I took out a small piece to shorten a little bit. You can see her sesamoids are abnormal. The hallux is in a pronated position here. She has a mild abnormality of the proximal articular set angle here. Another picture of the foot, a slight rotation. You can see on this view that she has a slightly elevated first metatarsal, which can also be corrected with this by dropping that head down just a little bit after you make your bone cut. This is a clinical picture of what her foot looked like. I know I'm not supposed to show you the tattoo, but I'm not sure how to get rid of that. So this is I'm putting the freer here at the first TMT because I needed to make sure of the exact length of the implant so as not to go into the first TMT. That's what this was here for, and I lined up the implant so I made sure exactly where this was going to sit. So this, we're making just a small incision over where the plate goes and where you make your bone cut, probably 1.5 centimeters, 2 centimeters here. This is without entering the joint capsule. So we made this transverse cut, and I also took a little wedge out to shorten the first metatarsal. This is probably the limit of the correction that you're going to be able to get with this implant. You can see that if I had tried to make this any more proximal, I would be going into the first TMT here. So this is, you can't really see that the head's dropped down, but it's dropped down just a tiny bit here compared to what it was. But this is a small medial incision. I tightened up the joint capsule and put a suture from the joint capsule into this implant to tighten up the capsule on this side. And then this is a small lateral release that's performed with a small beaver blade. This is a picture of the nearly immediate post-op presentation, and then this is what the bone cut looks like as it heals. And because you're not removing a whole ton of the periosteum, you end up getting this nice area of bone that's filling in here and remodeling. You could argue that she's had a tiny bit of recurrence here. Maybe you could do an Aiken down the road if you needed this a little bit straighter, but so this is kind of the way that I like to do this now. This is what her foot looks like after 8 weeks, 12 weeks of healing. You can see just a tiny little scar here. Again, this is the before correction and after the correction, taking a small wedge to shorten the first metatarsal, as well as derotate the great toe with that capsular correction. Additionally, when you're putting in this implant, after you've driven the screw, if you find that you need a slight bit more correction of the articular surface, I tamp this with a bone tamp, and by impacting this a little bit more, you're able to derotate the head just a tiny bit more to dial in that correction just a little bit. Here's another case report, 51-year-old female, anxiety and hypercholesterolemia is past medical history. BMI of 31, intermetatarsal angle of approximately 16. This is a great little app if you need something to measure angles, pinpoint app. I use this a lot just for what it's worth for you guys. So about a 16-degree IM angle, 18-degree hallux abductus angle. Here's your lateral view of this one. You can see a little bit of first med elevation on this presentation, probably a little bit of limitus type deformity in conjunction with the bunion deformity. This one you can see I've plantar flexed the head here, as well as shifted it laterally. There really wasn't much more room to shift this further laterally. This, I've also taken out a small wedge here to derotate the head during this procedure. You can see here that the limbs of the implant can cross each other inside the medullary canal. That really doesn't mean much other than just that it's in there very tightly. Again, this is our second case report. This is her initial incision intraoperatively. And then this is what she looked like at about 19 days out. I think that you're seeing a lot less swelling, a lot less bruising with this procedure, especially if you're able to not enter the joint capsule, limit your periosteal dissection. I've been quite pleased with how soon these people look and feel good. Again, this is the same patient, the pre-op, the post-op, 19 days up and close here, limited swelling, limited bruising. This is the patient that we saw that I showed in the beginning. This one, a nice splay foot type deformity, IM of 18. This is probably one of the larger bunions that you could fix with this. Hallux abductus of 28, your Taylor's bunion, 4th and 5th intermetatarsal angle of about 12. For the Taylor's bunion, when I'm correcting this large of an angle, I like to make a base type osteotomy and shift the whole 5th metatarsal over and then put a plate on there. So that's what we're seeing here, the plate fixation for the Taylor's, the bunion correction here. This is one of the earlier ones where I was going into the joint capsule, which now I do it much more proximal, or a little more proximal, and try not to enter that joint capsule. So this is, you can see that this is probably a good 50% of a good shift from shift laterally here. Again, on the right here, you see the small plate and screws for this Taylor's bunion correction. Initially, this is always kind of a scary type thing before you realize how this is going to heal, to wonder if this is going to fill in. This is this patient immediate post-op on the table here, and then what she looks like after she's healed. The interesting thing with this patient is that she showed up about 2.5 years later having symptoms from this 5th metatarsal hardware. You can see there's some broken screws in here. She wanted this taken out, but you can see how well this bone heals and remodels 2.5 years down the road, and maintained a nice correction of the deformity. And I like how there's very little scars here too. This is a 4th case presentation. This is a large bilateral bunion deformity. This patient wanted both fixed at the same time. No medical history. IMs of approximately 15 on the left, 14.5 on the right. I mean, give or take a few degrees. So she wanted these fixed at the same time, which when it's weight bearing immediately, I'm happy to do it, but you know, if it's a much larger bunion, I don't think you could do that. Again, here are the angles drawn on this screen here. This was the correction that was achieved initially. Again, this is one where I did the bone cut a little more distally. This, you could argue, is almost into the joint, but this wasn't symptomatic initially, but down the road she did want to have the hardware removed here. So again, I would make this a little more proximal in the future, but you can see that it's remodeling nicely here. So since she wanted these removed, this was about a year after the original surgery, went in, removed these implants, shaved this prominence down a little bit more, and redid some of the capsule work because she wanted the bunion just a little bit straighter. She wasn't completely happy. So this was her result after the second surgery, after we tightened up the capsule a little bit more, removed the hardware. This, excuse me, this is the 5th case, 44-year-old female, rheumatoid, arthritis, anxiety. Again, another bilateral case, 14 and 12 IM angles. This is clinically what she looked like, small prominence, not too bad. This is probably the ideal patient, someone who has a somewhere mild to moderate, not too severe of a deformity. This is this patient's correction. This was one of the initial ones where I wasn't making it too proximal. We have a good 50% or 60% shift of the metatarsal head. I tamped this implant in a little more to derotate the distal metatarsal articular surface on both sides here. Again, this is a shot from the lateral where you can see the implant limbs crossing each other. So nice small incision here. I'm showing you this case, one, because it's bilateral, two, because I think it came out pretty well. And this patient was happy enough that this was the last time I ever saw her, was after we took these x-rays, and I never saw her again after one post-op visit. So hopefully she's doing well. Any questions?
Hey, Dr. Palmer, this is Dr. Graham.
Hey, how you doing?
Good, good. I had a question about, in case number 1, you mentioned about suturing the joint capsule into the implant. Could you talk more about that?
Yeah, so let me back up here to this one. So there are, let me get in here. So sorry about that. Yeah, so there's, before you put the screw in, you can loop a suture through the implant here. Or sometimes I've drilled a small hole in this proximal part of the metatarsal here. I think in this one, I think you can see a tiny little drill hole here where I've taken a PDS or some long-acting suture and go through the bone or the implant, and then by going up underneath the skin, you can grab this capsule and tighten up the capsule without actually entering the entire joint or without stripping everything off. So through the small incision, you can kind of go up underneath there and grab that capsule and tighten it up a little bit. Does that make sense?
Yeah, okay, cool. Thank you.
Yeah, sure.
Dr. Palmer, this is Tyler Gloshot. I have a quick question.
Tyler, how you doing?
Doing well, thanks. So that ridge on the proximal portion of the metatarsal on the medial side, do they ever feel that through their skin, or is there sufficient enough soft tissue that they doesn't affect them?
This portion here where the cursor is?
Yes, yep.
I haven't had anybody complain about that specifically. I mean, the main complaint, I always try to take off a little piece of that just to smooth it down, just in case they would feel it. And the only real complaint is sometimes people can feel the implant, but even that's pretty rare.
Okay, thank you.
Sure.
Hey, Kevin?
Yes.
That's great. Can you do a favor? Can you show me how you're measuring when you go that far back with the implant? How are you measuring where to actually do the cut in that case?
Well, so for this, I lined up the freer with the articular surface of the first TMT, and I put the implant on top of the skin so that I could mark out, where I would need to put the screw. And then based on where the screw is, the bone cut, has to be 7 to 10 millimeters from where the screw is, so you have enough real estate. So there really is no other measuring device other than laying it on top of the foot itself. But I'm trying to see if we can change this implant a tiny bit. But right now, this is probably the most proximal cut you could make.
You probably should come up with a slightly shorter one.
That's a good idea.
Do that.
Yeah.
Yeah, I did one where I did it like the way you described it, and it actually came out the base. It wasn't there immediately pre-op. It looked fine. I guess from walking around post-op, it protruded about 2 millimeters out proximally by the interspace. It's just brittle, but on X-ray, it don't look too great.
Yeah, I think that's like the catch is you got to be careful with, if you're going to do a little more proximal, cut exactly where this thing's going to end up so that it doesn't, go too close to the joint. Yeah. So I guess another thing to show you on this slide here versus some of the other ones, as far as frontal plane correction, since you're not going in and cutting off this medial eminence here, you can put this head of the metatarsal anywhere you want it. You can rotate it, any direction you want so that your hallux aligns nice and straight, since you kind of haven't bought where that implant's going to seat, if that makes sense.
think the people, like the one you're showing now, are happier because the tip of that implant is like right behind that flare up.
Right.
And I think the people are happier as far as feeling that implant, when it's in that position like that.
Yeah, and and the joint moves perfectly because you haven't gone in and stripped off any of the capsular ligaments or anything other than releasing releasing the lateral adductor and a small portion of the capsule. But the joint still moves very nicely, and I think they have a lot less pain. They have a lot less swelling. So the way I did it initially, starting out more distal, I've kind of migrated it more proximally, and I think it's a little tricky to do it, but I think the results are much better.
Have you used temporary fixation like K-wire or anything to hold that rotation in place before you throw the screw?
Do I? Is that what you asked me?
Yes. You ever use K-wire to maintain the correction temporarily?
I did initially, but I found that it got in the way more than it was benefiting me. I kind of grabbed the toe and rotate it and position it where I want it, and then drill that screw while I'm holding it where I'd like it. So for me, it's just more simple to hold it right where I want it to be and to drill at the same time.
Gotcha. Okay.
Yeah. I think this implant's also great for the patients that need a pretty good correction, but like if you're doing an elderly patient, you don't want to make a large incision. You can get away with a kind of a minimal incision, but still have a pretty stable implant, as opposed to making a nice big incision that they may or may not heal as well. So I like the fact that it's a limited incision. It's not a minimally invasive, but limited incision, which I think is nice.
Kevin, you mentioned that you were discussing some changes with the implant with them. What were you trying to change?
Say that again. I can't hear you.
You said that you were speaking to them about making some changes. I was just wondering what you were trying to do.
Well, I was thinking about shortening the implant up a little bit, to make it for a slightly different indication. And then, I think it would be good to have one maybe to do Taylor's bunion correction with too, a similar type implant.
Right.
Yeah, so a few little tweaks maybe.
Right.